being focused on is the relationship between the primary care provider and the patient, and how third-party telemedicine services dovetail with that relationship. How is data shared? How when we're focusing on a care team approach, how does the telemedicine provider, if not part of the clinic model, fit in? These are important questions to consider. So I think the key to starting the design process is to make sure you identify the problem that you're trying to solve for. Too often we don't see employers having a clear definition of what the problem is that they're trying to solve for. So I think there's different key questions that you can ask. Usually it's around starting with medical cost trend. What's driving our trend? Do we have specific chronic conditions that we're focusing on? What are the healthcare needs of the business, both OC and non-OC? Do our members have access to high quality primary care? What does primary care access look like in a specific geography, not even just for the employer, but in a specific MSA? What's the value we are receiving on our healthcare spend today? And that can be very specific to specific service lines. So as we look at musculoskeletal, physical medicine, occupational health, where are we spending our money today? Is there a more efficient way to deliver that on-site or in some sort of virtual modality? And then I think also helpful is to think about what does success look like in 1, 3, 5 years? How are we going to evaluate this in 5 years when we look back? That these things can all help in the brainstorming process of identifying what specific problems we're seeking to solve, and it can be multiple. It's not just one. Clinics are multifaceted, have many different ancillary service lines, and really service the foundation for a broader benefit strategy. But we can't solve a problem unless we know what it is, so we need to define that. And here we're showing data from our 2018 survey, the top objectives listed by employers that responded. And these are really specific to your organizations and can be one or multiple, and they really serve as guideposts as you begin this decision-making process as you design a custom clinic solution. So, I think we want to keep some specific fundamental concepts front and center. They're often lost in all the detail of evaluating or considering a health center. I think the first is that underlying almost every clinic model is a shift from fee-for-service to fee-for-value. That's simply represented by this diagram here, and whether it's the patient directly or most commonly the employer paying that the doctor or management group with differing financial models, but really getting the provider away from the fee-for-service solution. Instead of receiving reimbursement for each individual service rendered, physicians receive a per patient amount each month, or you're paying on what's called a cost-plus basis, which is a common model in the employer-sponsored world. The model also detaches any influence insurance may have on the practice through pay-for-performance, prior authorization, and value-based purchasing policies. These are important things to include in the concept. The direct payment model really represents the physician with increased flexibility to provide services in a way that are desirable for patients, but were not previously billable. Things like phone conversations, email correspondence, digital interactions, even home visits in some cases. These are part of the overall fee, and it better aligns the interests of the employer with the specific clinic management organization. Specific to this administrative component, a study was done from the American Medical Association that found that the cost of billing and insurance-related activities for a single primary community doctor is almost $100,000 a year, or $1 and $7 out of every dollar collected. So it's important, and and understanding where the dollars are going is kind of fundamental to the design of a health center. Another critical component, another fundamental piece, this kind of goes back to the patient's primary care relationship, and the fact that that is driving value. Directly at the clinic, the provider and care team they're working with patients to manage their health. The part of this is that we're intentionally expanding the amount of time that providers get with the patient population. That allows them to focus on education, reduce lifestyle risks, and manage chronic conditions, closing gaps in care. That's a critical component, but the provider plays a key role in that they manage the member's journey through the healthcare ecosystem. The more that the health center has a role in that, the better. So when surgery is necessary, where does a member go? When a member's trying to make a decision about a specialist to go to, the primary care provider and their relationship is typically the first place they turn. They're usually going to follow their recommendation. Quality and cost can vary significantly from provider to provider, as we know, and the cost for the same procedure in a specific region can vary significantly, by as much as 50%. So that referral from the primary care provider is critically important. From a quality perspective, as we kind of simplify the value proposition within the quality component, why does that price vary so much? There's 4 specific domains within quality. First is appropriateness. The safest and least expensive procedure is the one that the person didn't need to get. Over 50% of spine surgeries are avoidable. The second concept is do no harm. We want to avoid complications of care. For example, no surgical infections, not needing to repeat procedures. Third is achieving the goals, the person that gets the expected or intended outcome, i.e. less pain or more mobility after a joint replacement. And the last concept is patient experience. The process of care and perceived outcomes are positive, i.e. the patient reported outcomes measures and the net promoter score. The clinic is really a way for the employer to drive to value-based care. At a fundamental level, an employer-sponsored clinic is different in that the staff is trained and programmed to refer into the employer's available benefits, and that's critical. So, and that needs to be tracked and reported. And but more important is these downstream referrals to community-based care, which can be the most costly. You need consistent and transparent tools to determine if members are receiving high or low quality care, or the cost of that care relative to the market. So we want the clinic provider to proactively manage the member's journey. We want whatever the staffing model to be, that for that concept to be present. And the more resources that we provide to support it, the more impact we may have. We want to give them these providers who are gatekeepers in a way. We want to give them a curated list of providers for referrals with cost information so that a member can make an informed decision that benefits both them and the employer. So driving to value is something to put at the top of the list. From with that in play, some of these fundamentals, there's a number of different decisions that, as I referred to before, make up the conceptual framework for a clinic. Often employers will come to us with a proposal from a vendor, often with a specific ROI, and ask what we think based on our experience. And what we find is there's really been not enough customization or exploration of what potential challenges might underlie the concept. The proposal often hasn't captured key strategic decisions that need to be made, or also hasn't captured all the costs, direct and indirect, that they might incur, or even the resources that you as the individual or stakeholder might need to dedicate to support the health center during implementation and ongoing. And along the way, major barriers can be identified that would decrease the likelihood of success. And I think that's important. There are reasons why health centers don't work. Upfront proposals or business cases may have positive intent, but in the end, we run into challenges along the way that need to be overcome. And so we want to be transparent and direct about what those challenges might be. But it starts with having a really thorough process of analyzing the different decisions up front. One thing not on this list is compliance, but that's one thing that needs to be reviewed. But it often starts with conversations around eligibility. Who do you give access to? Partly that's driven by the objectives that you set, the problems that you're trying to solve for, and typically that's focusing on in the enrolled employee population. But what other groups should be considered? What's the value proposition of each individual group? So do you give access to the non-enrolled? Do you give access to contractors? Do you give access to members that are on COBRA? There are pros and cons of each individual independent group, and you need to think through each one as a starting point. That kind of creates your base for who's going to have access to this. And there may be things that you put in the parking lot that will be evaluated with data. That's your first things. Services, there's a laundry list of different services that can be provided at a health center. Partly you start with understanding what your objectives are. So if giving members access to high quality primary care and supporting an on-site primary care relationship is your focus, that's going to be the core of your model. But it might not be. You might be focusing on occupational health. You might be focusing on just wellness-based services. And it starts by looking at what services look like today in services that your employees or members may already be demanding. That could include flu shot clinics or different wellness programs that you have available. What does that utilization look like today? Then you want to look at staffing. As you make these choices around what services you want to offer, you want to think thoughtfully about what staff you might plan to include in the health center. And depending on the size of the health center, that can be very complex. In most cases, most employers have single provider clinics, and it's a little bit easier. But you still want to think thoughtfully about the definitions of that position, starting with, is it a physician or a mid-level, or do you need a dedicated health coach? But you also want to think about information that could be taken from an employee survey about preferences for a physician versus a mid-level. Some populations, there's a clear understanding, even anecdotally, that employees won't respond well to a mid-level provider. And then, as you take data in, you take these decisions around initial preferences and you evaluate the overall cost and savings impact from having one particular staffing configuration or another. From a plan design perspective, this is a critical one. How will a plan support and drive utilization for your defined objectives? Do you want to offer an incentive to drive members to the clinic? If you want really high utilization, it's usually tied to a strong incentive program. Do you have a high deductible health plan with an HSA? That is going to be a critical thing that you separately need to evaluate. What do you need to charge members to satisfy IRS guidelines for HSA accounts? And then thinking through what impact will that have from a utilization perspective in our feasibility model. We know that from our direct experience as well as survey data that members with a high deductible health plan and HSA use clinics less than those without. So these are critical things to think through, and partly that needs to be put in context with what your existing incentive programs look like today. From there, I think we need to have a work stream that really focuses on facility, and I think this is a critical component that sometimes is overlooked. We don't talk about how facility design has a direct impact on the patient experience or the levels of patient engagement. And there are evidence-based practices and that lead to better outcomes. But it starts by understanding just kind of basic building blocks, and again, avoiding major stumbling blocks or challenges, but in where we choose to put the health center, including, is it in a high traffic area? Is it difficult to find? Does our facility have limitations on where signage can be placed to direct members to the health center? Thinking through specific number of parking spaces that need to be available. For some employers, parking is a major premium. And so we've had major battles with union groups or with different stakeholders around being able to designate a certain number of spaces so that either employees or even their dependents, if eligible, would be able to park and then have access, not to mention going through challenges with security and the issues there. So we need to be thoughtful and have conversations with from a planning perspective, as well as different stakeholders within a specific site who may have knowledge about these different decision points, and we want to gather their input as part of the process. And it's another kind of stepping back from that is another potential problem that we see, is that for larger organizations that have multiple locations, that decision makers don't early enough bring on the stakeholders at the site level, and that can cause pushback or miss some information that would have been important in the design decisions. Part of that is understanding the culture, not just of the national or broader enterprise of the organization, but also the culture at that specific location. And culture can vary by site. Big concepts of, is it a call center? How likely is a specific population to engage in a health center? But also kind of thinking through managerial policy at that location. Do managers support members, employees using the health center during the hours of operation? What's the process going to be if somebody has an appointment during business hours? Or even, is there kind of a potential for employees or managers to look down on specific groups that might use the health center? We've seen in back-end audits and employee focus groups, employees admitting that they felt they would be persecuted if they left their desk in the middle of the day to go to the clinic, that their colleagues on their left or right, or even their manager, would view that negatively. So these are important things to really think through up front. And then the last topic on this page that I want to focus on now is integration. The integration of the health center is often something that is talked about in concept, but isn't followed through on. It might be on the list in how the health center will refer to available programs, but then tactically it doesn't happen. Either that the appropriate interfaces aren't built between your other vendor partners or the community and the clinic-based provider, or even just basic things like the staff going through an annual training on the current benefits and changes from year to year. And that's really where the rubber hits the road. We want the clinic to be not siloed, but a fully integrated piece of the employer ecosystem, regardless of the model that's chosen. And there may be some hard work in building those process flows and business rules, but that's where the value is found. So we included some data in here from our survey that we did in partnership with NAWHC in 2018 to show the potential options here, the choices on here, which could be driven by different choices of ROI, potential space, economies of scale. These are often factors that support the decision of offering one service or another. In general, the more services that can be offered beyond the core primary care services, so ancillary services, the more you offer, the more engagement that you're going to see, because every time a member engages for that specific service, there's an opportunity for the clinic as a team to be working together. So in highly functioning population-based programs, the clinic team has aggregated data that is presented to members of the team on patient lists, so that if a member engages, the provider or somebody on the care team can understand if there's gaps in care, and they can immediately engage the patient to manage their health or get them to one of the care team members for appropriate management. Services that from this survey, and we're seeking to do a refresh of this survey later this year. The ones that are growing the most are behavioral health, both on-site and virtual, physical medicine, physical therapy, both on-site and virtually, and then even vision and dental services, ancillary services, things that there's different solutions, companies like On-Site Dental that can come in and set up pop-up clinics, temporary solutions that either in the physical walls of the health center, or even in nearby conference rooms, and can be an extension of the general on-site, near-site concept in offering, as well as an integration point. We know that through vision and dental, there's opportunity for screening and early identification of chronic conditions. So it can create foot traffic as well as another referral opportunity into the clinic, and then managing downstream utilization. Clinics are often the foundation of the employer's wellness program. This can vary based on the size of the organization, but in often cases, the health center and the programs that are offered are really a physical manifestation of the organization's commitment to wellness, well-being, a culture of health, and it can make sense depending on the employer that the clinic is leading these efforts. A clinic's technology infrastructure can really drive population health, and it can also help get away from point solutions, which often are siloed and not part of kind of a broader holistic strategy. So it can, the clinic-based platform, and depending on the vendor, that it can look very different, but it often has data analytic tools that aggregate data, so medical and pharmacy claims, EMR data, health risk assessments, and biometric screening data. And then the clinic can take that data and risk stratify the population and identify gaps in care. Then when a patient engages for care, like I mentioned with the ancillary services, the provider has a clear list in front of them to say, hey, you're due for a screening, or I see you didn't fill your prescription. Here, let's take care of this now. So like the clinic may have a mini dispensary on site, depending on if state regulations allow it. So they can immediately fill a maintenance medication. The clinic can also really be proactive, and this also can vary by the preferences of the employer, but it can proactively reach out to patients to close gaps in care. So the data can drive patient lists, and then the provider or health coach, based off of previous interactions or through broader campaigns can reach out to the members. That can be individual calls. It can be broad campaigns with condition-based programs, with focusing on different modalities of engagement. Employees can often are responsive to combination of modalities based on the nature of their job or their demographics. So use of different modalities like emails, texts, even home mailers that are getting in contact with the dependent population or spouse. These are different ways to reach out and not just wait for somebody to walk in the door, but to reach out and close the gaps. So, I think as you think about what model makes the most sense, depending on what you're planning on doing, whether it's an on-site solution or even with multi-employer community shared solutions, it goes back to that concept that the employer has control, is in the driver's seat to make decisions. And the more this is focused on your employees, the more control you have. The size of the health center will drive different decisions around what types of staff you need. Often cases, a physician may not be the most cost effective, because really a physician should be deployed to really treat at the top of their license. And often case, that can, if they're not treating at the top of their license and they're managing too much acute episodic care, that can lead to provider turnover. Which can really damage the patient experience, not to mention that research shows that there's value in the patient-provider relationship. So just disrupting that relationship by having the physician role turnover damages the patient-provider concept for that clinic, and will lead to an increase in downstream spend in inpatient admissions, ER, specialist visits. So we really want to be protective of that, and avoid provider turnover. So the choice here is important. So if we don't have a strategy on keeping the providers satisfied, we want to think about other ways that we can approach things. In a community-based shared model, it may give us the economies of scale to have multiple providers, a physician and a mid-level provider. Depending on how many employees we may have more influence in that decision, or if a near-site clinic is being built in partnership with another employer. If you're serving as the anchor employer, there's often more opportunity to define the scope of that specific health center. So we need to think through different decision points. I think also is, as I was kind of alluding to before, when you have a clinic only for your dedicated population, you have the opportunity to really customize the provider that's chosen. The cultural fit is really important too, and that can be driven through interviews and being involved in the interview process, but also in defining the job requirements and thinking through, do we have language requirements? We've worked with manufacturers that have 10, 15 different languages that are spoken within a specific site. So how do we manage that? Do we need to have a bilingual resources? Do we have different team members that speak different languages, or we just use a language line? How do we manage that? Or also just, again, through an employer survey of the potential eligible population, is there a preference for a male or a female? And that can be deduced up front before we make a mistake and introduce a male provider to a population that clearly has a preference for a female. So I think we need to be thoughtful as we make these decisions on every level, and the more we have an open dialogue with a potential management organization, the more we customize the fit for our specific population. Included this slide. It's not meant to be an eye chart, but it's critically important. I continually will say, if you can't measure it, you can't manage it. And too often, there's mistakes are made in that we're not establishing what key performance indicators are at the beginning, and we're scrambling in year 3, year 5, and saying, can we measure this? So and we're finding out that the chosen vendor manager and their technology platform isn't able to measure, track, or report on a specific metric. And so this ties back to that original discussion of how are we going to measure success? What does this look like? What are our target levels for years 1, 3, 5, and then let's measure against that for the total population as well as the engaged population, understanding how successful we were. And part of this is that while we can try to measure everything on this page, and even many more metrics that aren't here, what's meaningful to the organization. So I think it's important to think about who are the stakeholders that need to be involved in this, and what questions are they going to ask, and how are we going to answer them. We have those conversations up front and set expectations that in the development of the business case and plan of how this will be measured, and specific definitions of how these will be measured. Are we going to use HEDIS? Are we going to use some other benchmark? And clear, open transparency is the driver. And then I think as you do this prior to engaging with a vendor partner, that can help drive your decision of, is this the appropriate vendor partner for us if they can't measure a specific set of metrics or provide us the reporting that we feel is necessary so we can be accountable on the back end and measure success. So underlying all that in what I broadly call maybe a business case is a more specific need to do a feasibility study. These can be extremely complex, but they don't have to be. There's simple ways to do feasibility studies, but you can go as deep as you need to go to really understand each of the potential sources of value. In the end, feasibility studies are directional. We set a series of assumptions and project what we think might be experienced, but in the end, we don't know who will be successful in engaging with. We don't. There's many things that in potential outcomes that can change the potential results. So we want to think about different scenarios. What is the expected value and the cost of this proposed strategy. It's important to capture all of the components of value that the business may recognize. As an example, for some, productivity is critical. For others, it's too soft of a measure to include. So we need to think about what is part of a feasibility study, and it really starts with taking a baseline data, for baseline data for the population, and that can be 1 or 2 years of data depending on the type of analysis you want to do, and then projecting how many people might use it. Measure how many visits for those users will be generated for each service line, and put together a specific operational model that will be designed to fit those specific projections of service and utilization. The potential cost is really driven by the potential financial model that you want to move forward with, and that can lead to just specific vendor partners that operate using different models. So there's many different variables that could influence what those final costs might look like. But having these pieces in place really give you the baseline to estimate what savings might be generated with different potential vendor managers, program partners. The key to this, in our opinion, is running different scenarios. So it's unrealistic to put your stake in the ground and say, this is how it's going to happen. We know that we're going to achieve this amount of utilization, and we're going to reduce inpatient admissions this much, and it's just not reasonable to think that it's going to play out exactly how we think. So what we recommend is running different scenarios. This can be scenarios that evaluate different options within the planning model, the different type of provider that we're using, the different groups that might have access. But the most important piece is to really think through best case, worst case, most likely case of levels of utilization as well as different levels of program impact. We don't want to be 5 years down the road and saying, we never envisioned that outcomes could look like this, that we wouldn't get the right level of engagement, or we thought that this program impact was a guarantee, but what did the model look like if we weren't able to achieve that? And having that information is also very helpful as you're trying to manage the health center in the early years of identifying, are we on track? So having those key performance measures in place then will inform, well, are we engaging the right people? Are we successful in getting the high risk group? Or so do we need to change, course and do more marketing and engagement to get to that group? Because I think you can, if you're paying attention in those early years, you can see that we're not having the success that we were, projecting. We want to have this kind of potential playbook at our disposal should change be needed. So, lastly, before we kind of open it up for questions, I think it's really important to create a structure for management of the clinic that that includes the different stakeholders. That includes your broker or consultant, your vendor manager, specific leaders within your organization, and have a governance structure for managing the health center that's aligned with your vendor partner or management model. You don't build this and walk away. You really need to understand who's going to be owning this from the vendor perspective, but also who's going to be owning this within your organization, as well as having a successor. Too often we see the solutions implemented by innovative, thoughtful individuals, and then it's not passed down to the next generation, if you will, who understand what the objectives were and what the structure is for managing the model going forward. So the clinic can get off pace or off direction if somebody else takes over that doesn't understand. So this kind of sets a process of continuous improvement where we're managing this on a regular basis, monthly, quarterly, annually. And another component of this is that clinics will evolve over time, and they do that because they are reacting to changing priorities and objectives of the employer, and that's often driven by a changing healthcare environment. Plan design changes, different program changes, the demographics change. And too often the clinic doesn't change with it and just stays the same, and it needs to be reevaluated. So this kind of basic structure here helps to set expectations that there's things that we need to stay on top of. As going back to my original example of telemedicine and different solutions that are currently being utilized in the employer clinic marketplace, that didn't exist 5 or 10 years ago, and even just 9 months ago, it looked completely different. So we need to be regularly evaluating things moving forward and making sure that our plan for the health center is up to date and current. So this has hopefully been helpful, and welcome to open this up to questions. And I think Larry's maybe have been tracking that.
Great. Thanks very much, David. This is a wonderful overview. And I think for anyone who's tried to get into this type of benefit strategy, you learn that there's quite a bit that's involved here. Now, I would encourage everyone to click on the Q&A icon, submit your questions to David. We've got about 7-8 minutes for you to do that. This is a great opportunity. David's one of the leaders in the country in assisting self-funded employers in understanding this strategy and how to best go about it. So I would strongly encourage you to do so. David, let me kind of ask you briefly, what are some of the key challenges that are presented from senior management to, say, an HR benefit person who's looking to develop this, and how can they best overcome that?
Yeah, I think um, probably the number one is just the capital investment that's required, and often the most challenging piece is convincing a CFO that this is worthwhile, that they're of understanding the potential value to the business, and partly that is being prepared and well educated on what research is out there that that shows the value of a health center, and really tying that to the data specific to the organization of that this is applicable to that specific location, and that can be a combination of things, but often benchmarking and having done your kind of due diligence and being prepared for those questions, I think is critical to answering, because oftentimes if you don't if you're not able to answer those questions in the first pass, you may lose momentum for the initiative. So you want to be prepared for all eventualities when you sit down to pitch it.
Great, thank you. Also, let me ask, how does somebody know who to send an RFP to? Should they always send something to the local hospitals? Should they always send something to the largest providers? What kind of guidance? And then how many entities, if they're not going to self-manage, should they send something to?
Yeah, that's a difficult question. I think it starts by having an understanding of what model you want. So the kind of elements that I outlined today really drive that understanding, and then it's an understanding of what those organizations offer. Not all are capable of delivering a true advanced primary care model. Some explicitly won't offer occupational health, just as two easy examples. So I think that will start to narrow the funnel on who you might engage with. In our experience, there are challenges to working with local health systems, hospitals, in terms of understanding the downstream referral, and that can be a point of conflict with an employer group, but it can be overcome with transparency and contracting. And oftentimes, including local hospitals, health systems, is important, because they're a partner of that ecosystem, and there may be relationships at the board level, and they can be effective partners in specific scenarios. So I think you want to be thoughtful about who you send it to, but it can be a challenging process in terms of how much information needs to be reviewed. So you don't want to send it to somebody an organization that's not appropriate, because there's a lot of time and investment that goes into on both sides to evaluate it thoroughly.
Great. Again, we encourage people to submit questions to David while we've got him here live. David, the key question I get frequently from employers who are interested in this is, can they expect a quick return on investment, or what we call the value of the investment, in the first year? We're going to have a session tomorrow on measuring financial outcomes, but realistically, what should people be telling their senior management about an ROI, and what the potential is for getting a good value back very quickly, or should they set their expectations a little more conservatively?
Yeah, it's an important question, and our actuaries spent a lot of time evaluating the idea. I think it's important to be conservative, while we might we might see proposals that project very lofty expectations around how much of a decrease we might see in any specific category. Change takes time. This is underlying the success of a health center is changing employee behavior, and that's driven by engagement and utilization. So step one is getting an individual through the door. Step two is then really creating a level of trust and engagement. So we're not going to, see overnight success, particularly at the total population level. While you might have success in an uncontrolled diabetic, and keeping them out of the emergency room in year one or even month one, it takes time for the entire population to consider utilizing the health center. And then, as we think about things like lifestyle management, and reducing health risks, that type of thing takes, definitely months, if not years, to change people's behavior. So I think you don't want to set expectations too high in year one. And we've seen that on the back end in measurement and evaluation, that the kind of, as we look at it on a match control level, that it takes time to really move the needle.
Great, great. Well, thank you very much, David. It's been a wonderful overview. And as I said, there will be a copy of the recording of this